for joining us today. It's a great pleasure to have you here for the last session of the year. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome you all. My name is Aline Serfari, and I'm honored to co-host this session alongside Dr. Hilary Umans, who has been coordinating and moderating this series with me for now almost 5 years. This session takes a different approach from the case-based format we have been adopting since 2021. Today, two pairs of radiologists and surgeons will present, Dr. Paulo Helito and Dr. Gazi Huri, as well as Dr. Hilary Umans and Dr. Jonathan Ticker. Together, they will bring us both radiological and clinical surgical perspectives. At the end, we'll have a Q&A session. If you have any questions during any point, any time during the presentations, please put them in the chat box. And at the end, the speakers will answer them. Today's presentation will be recorded and available on demand on the OCAD website, which is ocadmsk.com, as well as on the YouTube channel of the Radiology Society of Rio de Janeiro. So it's my great pleasure to introduce Dr. Paulo Helito. He's a consultant musculoskeletal radiologist at Aspetar FIFA Medical Center of Excellence in Doha, Qatar. He trained at the University of São Paulo, and he specialized in sports medicine imaging, musculoskeletal MRI, and image-guided procedures. He has authored over 80 scientific publications, and he's an active International Skeletal Society member and frequent speaker at major conferences. Now, Hilary, please, it's your turn. You're muted, Hilary.
I found my voice.
Yeah.
Hello. Good morning, everybody. Good afternoon. It's my honor to introduce Professor Dr. Gazi Huri, who's an internationally recognized orthopedic and sports medicine surgeon at Aspetar FIFA Medical Center of Excellence in Doha, specializing in shoulder, elbow, and knee surgery, with a focus on sports-related injuries and biologic reconstruction. A faculty member at Hacettepe University, he completed his training there and a fellowship at Johns Hopkins University. Author of over 100 scientific publications, editor of 4 international textbooks, and holder of 3 patents, he received the Tuba Gepip Young Scientist Award. He's also an active member of leading societies. There are 5 of them, major orthopedic societies with lots of letters. And he previously served as president of Forte, promoting orthopedic education across Europe. Take it away, guys.
Thanks,
Paulo,
Hilary.
please.
I will share my screen, just a sec.
Thank you very much.
As I do it, I'd just like to add that here in Doha and in Turkey as well, it's 9 p.m. So I'd like to
Good
thank...
evening.
Yeah, thank you. I would like to thank Dr. Gazi that agreed to join me. He's in the middle of lots of conferences in Turkey, and he's a good friend of mine.
It's my pleasure.
So we're going to start. We're going to present 2 cases that are really beautiful imaging-wise and have some nice treatment teachings. So nothing out of this world, but I thought it would be really interesting to share. The first one is this 16-year-old male football player that had a fall and showed in our hospital with medial elbow pain. At the x-rays, we could easily see an avulsion of the medial epicondyle in the red arrows and a joint effusion. Nothing more than that. And so this patient underwent MRI to further evaluate the fracture and the degree of soft tissue injury. As you can see, he had a fair degree of swelling, And in the red arrow, you can clearly see the avosed fragment of the medial epicondyle displaced anteriorly. And in the yellow arrow, in the axial image of the right, you can see that there is a partial tear of the medial, the lateral ligament complex. But what's most interesting about this case is the anterior luxation of the ulnar nerve. So where we see the dashed circle, this is where the ulnar nerve was supposed to be, and the ulnar nerve was dislocated anteriorly, and as well as the fragment was also displaced anteriorly. But this luxation was really important to be noted and reported. There is a small degree of edema in the ulnar nerve, but I wouldn't say that there is a direct injury. As for the remaining findings, we can see in the coronal plane the displaced avosed fragment of the medial epicondyle, and in the yellow arrow, the lateral ligament, partial tear of the lateral ulnar collateral ligament. Sagittal images showed some bone bruises, but no major capsular tears and a small joint effusion. This patient also underwent CT to just to get a better view of the fragment, and I think the CT images are really nice. I'm not a big fan of 3D images, but I have to say that this 3D image is really nice, showing the fragment displaced anteriorly, and the ulnar nerve is would be passing at the side of the avosed fragment and displaced anteriorly. So this is an avulsion fracture of the medial epicondyle with luxation of the ulnar nerve and a lateral ulnar collateral ligament partial tear. Gazi, do you mind just mentioning what did you do here? And
Paulo, thank you very much for that great introduction and all the radiological presentations. It's a really very unique case for us. Just when you go back to the first APN lateral X-ray of that case, it looks like very innocent. So that's why this case was firstly decided to be treated conservatively in outside center of Aspetar. And then meantime, there was a major displacement of the medial epicondyle, which is really, really very unique in that cases, because this is the medial epicondyle is the point that all the flexopronator muscles are attached. So it's a kind of like avulsion injury, and because of that muscle contractions, these fragments get anterior and superior displaced. And also another interesting finding of that case that Paulo also mentioned was the ulnar nerve, because it was a kind of, and this patient came to me 4 weeks after injury. And since he is a pediatric case, already soft callus was about to exist in the elbow. And also some sort of ulnar nerve palsies, not paralysis, some sensational issues started to exist in the patient as well. So during this case, I decided to go open reduction, make an osteotomy, and also there was a huge callus around the ulnar nerve. So it was not just a kind of like a double screwing of that fixation, and also I completely released the ulnar nerve and make a like sort of subcutaneous transfer of the nerve as well. So in this case, which is, if you ask me as a surgical challenge, will be not the putting the screws for sure. The most challenge is the protection of the ulnar nerve from the callus and the bone tissue.
And we had a 4-month follow-up with a good healing of the fragment, and the patient was discharged for normal to go back to his normal physical activities.
You see, there's a super on the supraepicondylar region. Yeah. So this super was, if I wasn't treated this transfer the ulnar nerve on the subcutaneous manner, this super is going to entrap the ulnar nerve, and the main issue will be happen about the ulnar nerve paralysis. So This is what it is, and the results of the patients after 6 months, full range of motion. There is no cubitus varus deformity in that cases. I'm not expecting, I wasn't expecting, but you know, he's a pediatric patient, full range of motion and fully satisfied.
And the second case is a nice companion case. It's a 17-year-old male basketball player with a fall over stretch hand injury with massive swelling and pain in the medial and lateral aspects of the elbow. The x-rays showed a lot of soft tissue swelling, but no fractures and no significant displacement, we can say. But the MR showed a massive soft tissue injury. In the red arrows, we can see both the injury of the anterior band of the medial collateral ligament. In the yellow arrows, the massive injury of the lateral ligament complex and avulsion of the extensor tendons with joint fluid interposed. We can clearly see here the massive injury of the medial ligament complex, and as we can see here, the ulnar nerve is in its correct position, although there is also a tear of the of the posterior bundle of the medial collateral ligament. The sagittal images show beautifully the joint capsule tear, so this was a really extensive soft tissue injury. And so this is an elbow dislocation with capsular tear and complete lateral and medial ligament complex tear, but no fractures. Gazi, do you mind commenting on the following videos?
Are you sure?
Push play.
Of course. So you saw it's a kind of like, normally, according to literature, we call this a simple elbow dislocation because there are two types of elbow dislocations, which is the first one is simple dislocation without any fracture. The other one is a complex dislocation, the dislocation within a fracture. So normally we used to name this injury as a simple, but intraoperatively, when the patient gets and look under general anesthesia, you can see a huge valgus plus varus instability in that case, and here you can see it's like grade 3-4 valgus instability of the elbow, which means that it's complete tear of the MCL of the elbow, even for the lateral side, because I did the same examination for the lateral side and it was completely the same. And this is the dynamic examination of the elbow. When I flex the elbow, it's immediately anteriorly displaced and dislocated, and in extension it's reduced, which means that both sides are injured. The injury of both sides are severe, and we need to address both sides. So this is the intraoperative. So I did like double incision technique in that case. Here, this is the extensor apparatus, which is supposed to be attached to the supra lateral epicondyle, but it's completely peeled off from the lateral epicondyle, including the lateral collateral ligament as well. And on the right side, there is also the capsular. You see, there's a hole in the capsule. It's completely, and you know, the blood is coming out of the capsule. So it's very dramatic injury of the lateral side of elbow, which means that it's a huge posterolateral instability. What I did performed lateral repair in that case, because it's almost like subacute case. It was the 3rd or 4th week after surgery, and when I put the lateral side and anchor repair, you see an flexion extension. The elbow became stable only in flexion extension in sagittal plane, but still in coronal plane, the elbow was still unstable, especially in the valgus. So that's why I did a second incision on the medial side. Of course, the ulnar nerve was one of the most important structures that I need to protect, and I just get the ulnar nerve protected, and the technique called Tommy Jones procedure, which means like allograft reconstruction of the medial collateral ligament was performed in that case. So you can see the tunnels, and I used the gracilis tendon. It was 5.5 millimeters by 28 centimeters long. So I have a chance to repair the anterior and the medial band of the MCL, in that case with a double bundle. So this is the examination after surgery. You can see the solid results and the fixation of the medial and the lateral side when I try to perform the valgus and varus instability tests. Yeah, this is what I did.
Great. So just following just a quick discussion of the acute elbow ligament injuries and medial avulsions. So quick mentioning the anatomy, we have the main primary static stabilizers are the ulnotrochlear joint, the anterior bundle of the medial collateral ligament, and the lateral ulnar collateral ligament. Those are images from one paper we published in 2021. And we can clearly see in MR the normal ligaments, the posterior bundle here, the anterior bundle of the medial collateral ligament. It can have this striated appearance, especially proximally. As for the lateral ligament complex, we have the radial, the lateral radial collateral, and the main one is the lateral ulnar collateral, which can be a little bit more difficult to access because it's kind of oblique to our coronal plane, but it goes around the radial head and attaches to the ulna. And we have the mechanisms of injury may be like the valgus stress and flexion in throwing athletes, but as we are showing here, traumatic cases, I'm going to focus on those types of injuries. And usually we have a supination with axial force and valgus stress, which is going to create the pattern of injury. So the fracture dislocations, which are not not our cases, because especially the second one, because there is no fracture. Usually we have the ligament injuries, the radial head fracture, and the coronoid process fracture. And whenever those three are found, we have the terrible triad, which carries worse prognosis. And imaging is really important to assess the size and displacement of the fractures and the degree of soft tissue injury. As for the posterolateral rotatory instability, it's usually traumatic with varus and external rotation. It can happen in lower energy Fuchs injuries or repetitive microtrauma, and we can use the old Driscoll classification to describe the degree of injury. So it starts with the lateral ulnar collateral tear, then stage 2 will be a complete lateral ligament complex tear and joint capsule tear, and then we are gonna have in grade 3 the medial collateral ligament, and especially the grade 3B, which is the worst, is when the anterior band is injured. We can have the luxation without fracture, as we saw in our case, and we can evaluate the malalignment of the joint, evaluating, for example, the ulno-humeral incongruity or the posterolateral translation of the radial head. Whenever we have an elbow dislocation, we have to keep in mind as a radiologist to have in our checklist to assess the fractures, the ligament tears, the other soft tissue injuries, as in this case we had the extensor tendon tear, and of course always evaluate the ulnar nerve. And the imaging pattern can be really repetitive, as in this case we have the tear of the anterior bundle of the medial collateral ligament and the radial head fracture. Another case pretty similar, anterior band of the medial collateral ligament tear, and in the yellow arrow we have a tear of the lateral ulnar collateral. Gazi, we have maybe we're almost out of time. Do you mind just mentioning a little bit about the surgical treatment? When do you indicate surgery, and when do you do graft or repair?
Yeah, of course, it's a kind of like as you show in the slide, it's very clearly in cases like mild or partial, as you mentioned, and the posterolateral instabilities or partial injuries with a simple elbow dislocations, we most likely go with the conservative treatment, actually, because the main issue for the surgical treatment is always like elbow stiffness. So we are scared to get an elbow in stiff. So we always push to get on a conservative treatment if there is a partial tear, especially on the medial side, because we know that the medial side may heal better than the posterolateral side, which is also which is really important. On the other hand, if there is a kind of, as you mentioned, like terrible triad with the dislocation with the fractures, or as a high level gross posterolateral medial instability, as we discussed in the previous case, I go with the surgical instability, surgical treatments. The main treatment goal of that surgical is getting a stable, even the medial and lateral side stabilization with a very solid full range of motion. And the key point of the surgery is to have a solid and stable elbow and start rehabilitation as soon as possible. The first 3 weeks after these surgeries are the most important part of the period. So that's why we do it. If it's an acute cases and if it's like a avulsion from the bone, especially from the humeral side, I commonly go in prefer to do a repair. Especially I repair on the lateral side than the medial side, because in the medial side the mostly they get like mid substance there. So that's why on the lateral side it's better to repair. On the medial side we mostly go on the graft reconstruction. And also the other indication for me to use the graft reconstruction is the failed conservative treatment, which is older than 3 weeks. Of course, there are different types of grafts. In Aspetar, we have a chance to get an allograft, and also if you don't have it, we can use the palmaris longus as a graft, and there are several different techniques. And also, if it's a kind of a partial instability and you decided to go surgery, we do the internal brace with the anchors. So, yeah.
So just a quick touch on the medial epicondyle avulsion. It's the most common avulsion. We all know the ages of fusion, and the causes are usually traumatic. And the pattern of injury in imaging is really repetitive as well. We see the detachment of the medial epicondyle. Just bear in mind that the X-rays can really deceive you. So try to use the oblique views to avoid undermining the degree of displacement. And as for treatment, Gazi, I think this is our last slide.
Yeah, so in the medial epicondyle in avulsions, if it's like a non-displaced, definitely we go in the pediatric cases. Even in the elder patients, we go at the conservative treatment. But if it's about like more than 1 centimeter displacement results in valgus instability, we definitely go with an open reduction internal fixation. So because of the positioning of the cast is quite tough, and you need to cast the elbow for more than maybe 6 weeks, which may lead a kind of stiffness also elbow. If it's non-displaced, we go with the splinting, but if it's more and unstable, we go with the surgery, definitely.
Okay, so as take-home messages, we have the elbow injuries may have this predictable injury pattern, and imaging can confirm and stage the degree of ligament and soft tissue and bone and fractures, ligament tears and fractures. So we will see the ligaments that are affected, the degree of disruption, and the quality of the tissues. And always pay attention to the fragment sizes and displacement. The joint malalignment and the ulnar nerve is really important to keep in mind in medial ligament injuries and fractures. Thank you very much, Aline and Hilary, for inviting us, and thank you, Gazi.
Thank you very much.
I'm gonna finish here. There you go.
Yeah.
Thank you so much. Great presentation. Hilary, do you have a question? I don't see any questions from the audience. Should we proceed with yours?
I think so.
Okay. So it's now my great pleasure to introduce Dr. Hilary Umans. She's a native New Yorker. She graduated at Amherst College as a studio art major. She attended New York Medical College, studied radiology at Jacob Medical Center in the Bronx, and completed a fellowship at the Hospital for Special Surgery. She's professor emerita of Albert Einstein College of Medicine in the Bronx, and is on staff at Lenox Hill Radiology and Imaging Associates in New York City. She's the administrator of One Case a Day, OCAD, an international online MSK case sharing forum with 1,665 subscribers. As of last week, I don't know today, right?
As of last week.
She's proud to have established the annual OCAD Live meeting, to have created the website which archives the cases and videos, and to have launched the OCAD LinkedIn page, which highlights educational quiz cases and grows every day and has more than 1,000 followers after 1 year. It has been her great pleasure to create this case series with her dear friend Aline Serfati, myself. Thank you, Hilary. Collaborating now for 4 years, almost 5, in partnership between OCAD and the Radiology Society of Rio de Janeiro. Thank you so much, Hilary. Please take it away.
Okay, before we get to our case presentation, I'm delighted to introduce Jonathan Ticker, who has been in private practice as a shoulder surgeon on Long Island in New York for over 30 years, now is the Chief Quality Officer with the Orlin and Cohen Orthopedic Group. He's well-published and lectures extensively on the shoulder and specializes in arthroscopic approaches. These include 5 books and, more specifically, 6 publications on the subscapularis, which is the topic we will cover today. And I have to reshare my screen. Okay, everybody sees that? Yes.
Yeah.
So our topic is from the hidden lesion to subscapularis avulsion, and I'm handing this over to John.
You're muted, John.
Thank you. Again, thank you for the introduction, Hilary, and thank you, Aline, and your colleagues for the invitation to participate in this really wonderful format for education. So what I'm going to highlight briefly is the pathology that connects the subscapularis to the supraspinatus. And on the next slide, you can see some landmarks. This is a right shoulder viewed from lateral. On the next slide, what I'm showing here is if the subscapularis is torn and retracted, and then if you bring it laterally, in part related to how you're going to repair it, it also brings the supraspinatus laterally. Next slide. And that's advantageous for when you're doing a repair. Next slide. And it can do that because of the comma tissue. This is the bridging tissue between the subscapularis and the supraspinatus. And that's something we're going to focus on today. Next slide. And it's something that Steve Burkhart and I published some years ago, and he had a part in coining the phrase comma tissue.
Okay, so our first case is a 52-year-old male right-hand dominant administrator. He experienced 8 months left-sided shoulder pain, which failed non-operative treatments. Incidentally, he had a massive rotator cuff repair in his right shoulder 6 years prior, from which he's fully recovered. So we're looking at the axial plane images first. This is a gradient echo axial image, and this is pretty much the most cranial image that shows the subscapularis tendon. We can see the deep surface, articular surface fibers insert onto the lesser tuberosity, but there is an intrasubstance and bursal surface tear of the tendon, and the long head biceps tendon has subluxed into the subscapularis defect, and we can follow that down. Companion axial proton density weighted images show the same thing. I prefer the proton density weighted images, and you can clearly see that V-shaped defect with the bursal surface defect, intact articular surface fibers, and the intratendinous subluxation of the long head biceps tendon. In plane visualization of the subscapularis tear is disadvantageous in the coronal imaging, but we can see what is in essence that comma tissue, that bridging tissue between the supraspinatus and subscapularis tendon that Dr. Ticker illustrated so nicely. And now we're scrolling more posteriorly. We can start to see some of that intrasubstance subscapularis tendon tear and the super margin of the tendon and the medial intra-articular subluxation of the biceps. And as we move more posteriorly, we don't see the normal footprint of the supraspinatus tendon, as there's a complete supraspinatus tendon tear. We see the bright signal at the expected footprint and the waviness of the torn tendon. John, how does the stump of this tendon look to you in terms of repairability?
Yeah, when you look at this here, there's good size of the muscle. There's adequate tendon, and Gerber has published more than 15 millimeters of tendon is what you want to see, so that when you do put a suture in it, you can repair it back. And this is, for me, something that I can and should repair.
Okay, so now in the sagittal plane, you can clearly see the fluid signal where we ought to be seeing the supraspinatus tendon, which is completely torn and retracted. And as we scroll more posteriorly, we see the biceps tendon subluxed into the intrasubstance defect of the subscapularis tendon. We see that bare tuberosity at the expected footprint of the subscapularis. And I'm just going to progress here. John, you
So
want
to
to
give you
comment?
some landmarks, I wanted to show you some arthroscopic images, and here you have the coordinates. This is a left shoulder. We're viewing it from above, and typically the scope in how I do it will be posterior. So the next slide just shows it in vivo. You can see the arthroscope cannula coming from posterior. So that's our alignment, and we're in a sitting position. This is the pathology that you'll see. The next slide shows some of the orientation. The glenoid would be to the right, which is off the screen. The humeral head is below. And if you do the next slide, you can see the rolled edge of the subscapularis, and you see this comma tissue. This is the confluence of the superior glenohumeral ligament, the transverse scapular ligament. You know, it's usually not, and the coracohumeral ligament, it's usually not visualized, but it is now more medial, and the biceps is no longer covering it. So if we go to the MRI, so that little slip of tissue that's within the circle, it's the same tissue on the next slide you can see here. And that's what it looks like arthroscopically. So this is one video image. I'm hooking the comma tissue, but to show what we call the hidden lesion, we have to look down into the bicipital groove. And the next slide shows a still image, and now you can see in the circle, the next slide, this is that exposed portion of lesser tuberosity, and this is the tearing of the subscapularis. The next slide, and this is a still image on the left of the video. The next slide, and you can see damage to the biceps. If this continues, it will continue to sublux over the lateral edge of lesser tuberosity in a more medial position, and can lead to further involvement of the subscapularis.
John, I have a question. So we know that the long head biceps tendon becomes unstable because of the subscapularis tear. But if there's continued instability of the biceps tendon, does that exacerbate or enlarge subscapularis tear?
Yeah, hypothetically, no one's really studied it, but yeah, if you continue to sublux into the defect, you can damage the tendon adjacent to it. So that, yes, you can increase it. So just to show you the repair, I repaired the subscapularis in a near anatomic position. I then went into the subacromial space on the next slide. This is viewing from laterally, and the left is anterior, the right is posterior. So it's about a 2.5 centimeter tear. And then I did a double row knotless repair, one medial anchor, one lateral anchor. And this is the outcome on the next slide at 6 months for this gentleman. There you go. Shall we do the
Hey,
next?
plowing along, our next case is a 54-year-old male right-hand dominant construction worker with 1 year of right shoulder pain that failed non-operative treatments. Again, we're starting from the most cranial image in gradient echo axial images. I'm not happy about the degree of internal rotation of this image. That's really suboptimal for evaluating the anterior cuff and capsule and the biceps tendon, but we'll mention that again later. You can see it's not subtle. There's a full thickness retracted tear of the subscapularis tendon. It's retracted nearly to the glenoid rim. And again, we can see that medial dislocation of the long head biceps tendon. I want to point out in this more caudally located axial image that the edge of the retracted subscapularis tendon is actually somewhere right around where the arrow is pointing, where that robust, smooth, dark signal tendon is. It's not the intervening scar tissue that's bridging the gap to the lesser tuberosity. In the coronal plane, we see a full thickness. Again, this is going to be a complete supraspinatus tendon tear with I think, an adequate tendon stump and good-looking muscle. And in this case, we're moving progressively anteriorly, and we'll get into the long head biceps tendon. The white arrows are pointing to the retracted, torn subscapularis tendon, and the gray arrows are highlighting that bridging scar tissue that's extending to the lesser tuberosity. There we see what's near the anchor of the long head biceps tendon. There's the intra-articular segment, and here's the famous comma tissue, the edge of the subscapularis highlighted by the white arrow and the supraspinatus indicated by the blue arrow, and that intervening tissue, which Steve Burkhardt coined the phrase comma tissue. The corresponding T1 weighted images are most useful just to see the quality of the muscle, which looks quite robust in this case. Sagittal images show that it's actually a massive tear of the entire posterior superior rotator cuff, in addition to the retracted tear of the subscapularis tendon. Again, we have fluid outlining the bare lesser tuberosity with the intra-articular dislocation of the biceps tendon. We see the biceps tendon, and then here's that comma tissue. Remember, this is anterior, that's the coracoid. And again, that's the retracted edge of the posterior superior cuff. Okay, John.
So this is what you see arthroscopically. And we chose these two cases. One is at one extreme of what you would see in the comma tissue, quite small, and this is as large as it gets. And again, your orientation, the next slide shows some landmarks. Obviously, the glenoid to your left, the humeral head lower right, the biceps tendon with some pathology at the lateral extent of this image. And then straight ahead is the comma tissue. It's the entire confluence of this tissue. The next slide, just to give you an idea, they look, pretty similar. There's striations within the substance of the comma tissue on MRI, and you can see that on image. On the next slide. So I'm going to take you through some videos. So this is advancing the scope, and if we look medially, we can now start to see the rolled edge of the subscapularis right there. If you pull on the comma tissue, just like I showed in the schematic, you can pull the subscapularis laterally, and above you is the supraspinatus. Outside of this view, you're also pulling that laterally. So it really behooves you to repair the subscapularis if you can, because it's just going to make the rest of your repair of the posterior superior cuff easier. So this is that same patient. So still image. This is the subscapularis repair with a near anatomic position. The next slides show, this is viewed from posterior on the left mid view. You can see the anterior aspect of the supraspinatus is more lateral, but on the right mid view, the posterior aspect of the supraspinatus and the infraspinatus are more medial. That's something I'm going to have to repair as I bring it more laterally to the rotator cuff. And I did a single row repair, in this case with multiple anchors and sutures, to bring the tendon onto the prepared bony bed. And now the recovery is understandably slower. And the next slide shows.
And why was that a single row repair rather than double?
It wasn't fully reducible over the entire graded tuberosity, so I didn't want to put undue tension on the repair. So this is, quote unquote, a reduced tension repair. And that's how I use it. I'm not all one single row or double row. I use it when I need it. And if the tendon tells me a lot about how I want to repair it. Obviously, if the bone quality is not good, the tendon quality is not good, I'm also going to favor more to a single repair with less tension than a double row repair. And so here he is at 1 month, at 1 year, with a pretty good outcome.
Hey, I have our images. I don't know, Alina, do you know how I get our pictures off the images? Never mind. So most subscapularis tendons tear in conjunction with the anterior superior supraspinatus or larger tears of the posterior superior rotator cuff. Isolated subscapularis tears are uncommon and most are traumatic. I discussed this with Dr. Ticker, and he actually interprets this comment in a different way than I had understood it.
Yeah, so like this is a patient I saw last week, a 26-year-old weightlifter, and had acute onset of pain. You can see the intrasubstance tear of the subscapularis. The next slide shows the same image with the exposed portion of the footprint on the left tuberosity. And then the next slide, again, similarly shows where the biceps can sublux into that position.
But what you said to me that I was surprised by was that a tear like this isn't that uncommon. You said it's the retracted tears that are uncommon.
Yeah, the complete retracted isolated subscapularis tears are much less common. And I do probably 60 or 70 subscapularis repairs a year. So
another interesting thing that I learned preparing this with you is that when the subscapularis tears in conjunction with the supraspinatus, you have the advantage of the bridging comma tissue to prevent the massive retraction of the subscapularis. If the subscapularis is torn and retracts in isolation, you don't have that.
It retracts more immediately and it atrophies more quickly. That's correct.
So it's more time sensitive in terms of imaging and reporting that. So it's very basic. I think we all know that the subscapularis tendons start to tear at the superolateral insertion and propagate inferiorly. Importantly, there's a intimate anatomic relationship between the subscapularis and the long head biceps tendon. The cranial insertion of the subscapularis interdigitates with the most anterior fibers of the supraspinatus tendon, and also interdigitates with the coracohumeral and superior glenohumeral ligaments. And it's actually bursal surface fibers of the subscapularis that contribute to what becomes the transverse humeral ligament to be the roof of the bicipital groove. So when these structures tear, it's not surprisingly that there's a strong association with long head biceps tendon pathology. We can see the supraspinatus tendon tear in the coronal image, and in this axial image, here's an example where that the bursal surface fibers are not retracted because there's contiguity with the transverse humeral ligament, which maintains insertion onto the lateral margin of the bicipital groove, and we see the intra-articular dislocation of the long head biceps tendon. And I think I think we've emphasized all there is to know about the comma tissue, but here's another such example. I just want to make my pitch for how undesirable it is to position patients in internal rotation. I haven't managed to prevent this in my own practice, but ideally you want to see the bicipital groove pointing straight up. And that way we don't have the laxity and the, the redundancy of the subscapularis tendon. We don't crowd all of the anterior capsular structures, and we can see the taut tendon and the long head biceps tendon where it ought to be. When the pathology is obvious, as in this case, it's not problematic. That transverse humeral ligament can keep the tendon from retracting. And you really have to be aware of the fact that you can have a complete delaminating type tear of the subscapularis that's really holding on by a prayer through that transverse humeral ligament. You should always scrutinize the sagittal and coronal images for signs of the subscapularis tendon tear, but when there's extreme internal rotation, you're compromising the sagittal plane images also. And again, I think one of the pitfalls, a major pitfall in maybe underestimating the degree of a subscapularis tear is misinterpreting the bridging scar tissue. Here I'm showing the normal-looking muscle actually, and the tendon, and that bridging scar. That's not tendon. This is a complete retracted subscapularis tendon tear. And here are some references, including two very practical and easy to understand illustrated reviews on the topic that taught me a lot. I recommend them. Okay, I think we are ready for the Q&A.
I don't see any questions, but I do have a question, Hilary. Oh, you do, Paulo?
No, but go ahead, please.
Do you use any classification system to report a subscapularis tear, or you just describe it without using a classification system like LaFosse, for example? Yeah.
Me?
Yeah.
I'm not a great lover of classification systems. I measure all cuff tears in length and breadth, and I comment on a degree of retraction and the quality of the muscle.
Yeah,
Thank you.
Yeah.
Also,
I have.
I don't use, I mean, at arthroscopy, I'll say if it's 25 or 50% or 1/3, I can go between classifications depending upon what it looks like to me. But preoperatively, what I'm looking for is the quality of the tendon, the length of the tendon, the quality of the muscle, the position of the tendon. Those are, more important to me than because I don't know if the classifications predict repairability, so that's in this particular case.
The more I talk, I mean, we have two surgeons here, but the more I talk casually with my surgical colleagues, the more I understand they really want to know practical information. And it's a while ago now that Dr. Ticker said to me, if only I got the length and the width of the tear, I'd be happy, which is horrifying when you think that's not necessarily the norm. We should be measuring the tears. They need to know that.
Yeah.
What surprises me about working on this presentation is that we seem to be so late in the game to repairing the subscapularis tendon compared to the posterior superior cuff. I learned that the subscapularis muscle, we know it's big, but apparently it's basically about the same territory as the infraspinatus and teres minor muscle together. And there are so many muscle slips with a very long and broad footprint. It makes perfect sense that you might not have as successful a repair of the posterior superior cuff without repairing that. What took so long, John?
Just this used to be done as open surgery from a lateral saber incision. It wasn't easy to get to. When I learned first doing it open in the early 90s, you had to do a separate deltopectoral incision. But arthroscopy has definitely made it much more accessible. Diagnostically, we can understand it better than we had. So, there were definitely reasons why it was slow for the uptake. Not that we didn't know about it, in the 18 and 1900s publications, but at least we're there now.
Okay, there I see. Thank you. I see for Dr. Huri, how do you manage anteromedial coronoid process fracture?
Hilary and Aline, sorry,
Oh, he had
Dr.
this.
Huri just texted me. He's in between meetings, so I think he got disconnected or
Oh,
something. I apologize.
okay.
May I ask a couple of questions?
Sure.
So the supraspinatus, I've like since my training, I've noticed that the supraspinatus has some fibers that appear to attach to the lesser tubercle. So is this what we are? Is this what is actually the coma tissue? Is this
Well, that's
part of?
part of it.
Yeah,
Remember,
yeah.
it's comprised of fibers actually from the supraspinatus and the subscapularis at the extremes, and fibers from the crocodihumeral and supraglenohumeral ligament.
Okay, because I had a trouble saying, "Oh, this is a complete supraspinatus tear," and I would say, "No, the supraspinatus
You
appears
know
to
what? I
be."
have that problem every day, every shoulder MRI, and I don't know. Maybe it's
No,
it's
I've
a
given
cheat,
up on
but
it.
I report, I measure everything, and then my impression is it's a complete or nearly complete tear.
Yeah, yeah. So
I
I
mean, if
usually,
there are a couple of squiggly fibers holding on to the lesser tuberosity, it's not going to
yeah.
change that.
No, but if
Right.
we call it if we call that the coma tissue, then I'm more comfortable in saying this is a complete supraspinatus tear, and the coma tissue is holding it. This is why it appears not to be that retracted or something like that. And another question to Hilary. How often do you describe that the subscapularis is still attached to the transverse
I
ligament?
always comment on that.
Yeah, because
I-
it's something that I feel it's important because the subscapularis is probably not retracted because of this
Right.
tissue.
So I'll say it's a complete or whatever percentage delaminating tear of the subscapularis insertion with with contiguity with the intact transverse humeral ligament, and
Perfect.
that pretty much says it all.
Yeah, perfect. Okay. And I have one more. Sometimes those delaminations of the subscapularis, I feel it's quite hard to say if there are still fibers in the bursal surface or if it's actually a delamination or if it's a bursal, it's a articular sided tear. As the first case, I think that there was
Well,
a
I mean, certainly it's easy enough if we see that the biceps isn't where it's supposed to be, right?
Yeah,
And
yeah,
it
yeah.
needs to
No,
be
so I think the
communication into the joint.
subscapularis tear is I think it's fair to say that we can see the subscapularis tear, especially because the biceps is luxated or subluxated. But how important are those articular fibers to Dr. John? If there is a thin bundle of fibers or if it's an articular sided partial tear, how important is it for you to make this distinction?
Probably not as much if it's literally, so the deep surface, the posterior surface, the articular surface has a limited partial tear, as long as the biceps is stable. But I also have the advantage that you don't. I can examine the patient, I can palpate, I can test their muscles. So for me, that goes into the equation. If the subscapularis is not retracted and has a limited articular sided tear, it's probably less likely for me to want to intervene surgically. But
No,
the other
I mean
the other-
distinguishing the intrasubstance tear that in the attachment of the superior fibers of the subscap to a articular sided tear. How important for you is?
the intrasubstance is much more important, because if the biceps can sublux, then that's something that's going to lead to symptomatology for sure. But the other thing I was going to add is I like the coronal images, and I like to look medial to the coracoid, because if the muscle has retracted medially, there's typically a visual gap between the muscle and the coracoid. Normally, the muscle abuts the coracoid. That's where it stops. And it's not something I've ever published, but something that I've been viewing and referring to. And that helps give me some guidance on whether it's detached and retracted for my patients.
And I know that I asked you if there's a partial intrasubstance subscapularis tear and there's instability of the biceps, will you surgically address the subscapularis if you go in to do a tenodesis? What's the decision process there?
Patients where the subscapularis tear is minimal, it doesn't require repair. If there's no common tissue involved, so then it hasn't retracted medially, then I may leave it alone. It depends upon the case, but I've done just isolated biceps tenodesis procedures, and then the subscapularis tear doesn't progress further. At least, that's been my approach over the past few decades.
Okay. I think I've learned a lot.
Yeah, me too. Thank you so much. Thank you all for joining us today. This marks the last session of the year for the MSK case presentation series. Please stay tuned to our social media channels for updates, and have a wonderful break. And thank you all for being a vital part of our community. Bye-bye.